Huge honor and privilege for me to be here. I'd like to just say that I give you a few disclosures. I work as a volunteer. I'm a layperson. I've recently accepted a position unpaid with the University of British Columbia Faculty of Medicine, which is a great thrill, and it's great to have an anchor on the planet with the work that I do. I'm going to present a familiar model of care. It's the traditional model of care for the surgical patient, and it is a model that may harm the patient and that harms practitioners. This is not a wrenching story of tragedy to move your heart, but rather a chance to see the perioperative experience from the patient's view, from the whole system point of view. For the patient experiences the entire system of care, while you may see only a glimpse from your silo. So I'd also like to suggest that ERAS implies culture change. I'd like to introduce to you my husband, Nick. He died not quite 6 years ago, just 8 days after successful surgery for an aggressive soft tissue sarcoma on the back of his thigh. To be clear, I have no medical background, and I've been learning on the job of widowhood. We were fortunate to fall in love and share 35 years together. With our 20-year age difference, we had lived life to the fullest, and it was an extraordinary life. This is Nick just a few weeks before his surgery, while undergoing preoperative radiation. You will recognize that this is not a frail 79-year-old. During the 7-hour surgery, the general surgeon excised a fully encapsulated tumor, and then the plastic surgeon rearranged some muscles and sewed up the incision with a small skin graft with a single drain. Here's a diagram. This is my invention of Nick's postoperative experience. The abbreviations are just my shorthand. So time goes from left to right, care intensity across the top, the condition of the patient along the bottom. The most responsible physician, the general surgeon, was very pleased with the surgery result. When he came in to see Nick, Nick was pain-free. He had a full range of motion in his foot and good strength. He offered a very favorable prognosis that Nick would soon learn to walk and on this re-engineered leg and would be discharged within a week, probably with crutches or a cane for a little while. So Nick enjoyed one great day of recovery. We met with the occupational therapist to plan ahead, but this was not to be. In the middle of the night, Nick was overcome by violent nausea, continuous watery diarrhea, and a fever. Coinciding with this was delirium, which denied sleep. With a holiday weekend came a new attending physician on that surgery ward. The symptoms continued to worsen with an increasing fever. The third day of the symptoms, a fecal sample was finally sent to the lab and came back quickly with a C. difficile diagnosis. Nick was immediately moved to isolation. I was taught contact precautions. The gastroenterologist appropriately treated Nick with an aggressive scheme of antibiotics. After a few days, the C. diff symptoms began to subside, but the delirium persisted for poor sleep. Nick was the person I knew and loved when his eyes were open. When he closed his eyes, vivid imagery prevented rest. Food was also withheld because of the C. diff symptoms. And Nick never left his bed. The Foley catheter was left in place. With increasing weakness, Nick's chest congestion also worsened. There was some blood in the urine, so a urology consult was called. It was intermittent, so orders were left. Come see me after discharge. Nick had many of the comorbidities common of his age. One was non-insulin dependent type 2 diabetes. I thought a consult would be a great idea. After an interview at bedside, the endocrinologist ordered some tests on unrelated and asymptomatic nodules on Nick's thyroid that he noted on a preoperative ultrasound that happened to be in the chart. The lab report that would come back later chillingly notes the patient was moving too much from obvious discomfort to conduct the ultrasound-guided needle biopsy on those thyroid nodules. The lab tech also noted large pleural effusions. On returning from the imaging lab, Nick was in pain. The gastroenterologist arrived and Nick asked for an NG tube and suction. Out came tarry old blood mixed with bile that had been filling his stomach. Other vital signs were beginning to change. His INR was climbing. It was not clear exactly what was happening. The night shift RN came on duty with a crashing patient, although she could not know that. She was on her own to sort out a confusing stack of orders for blood work. And then, at 4 a.m., Nick was found unresponsive by a lab tech, and who had yet again come to draw blood. So the symptoms had been matched to specialties, and no one had strung together those snapshots into a moving picture of gradual deterioration that was excelling to catastrophe. The autopsy would reveal Nick's unexpected death was due to a massive GI bleed. I would tell you, on retrospect, with my sophisticated analysis, that it was a stress ulcer. With hindsight, though, I would say that he died of silos. That morning, though, what I knew is that Nick had received compassionate and excellent care. I had been prepared for 35 years to outlive Nick, but I was not prepared. In fact, I was devastated by the damage that was done to the bedside carers. And it was I who consoled the bedside nurses who were convulsed in sobs. And also the surgeons who arrived, who responded to my heartfelt thanks for their excellent work with "so what?" and headed off to a long day in the operating room. I look forward to learning what had happened, to help these caregivers recover and to prevent this from happening to other patients. To my astonishment, this would not happen. I could not accept that a system could be so perfectly constructed as to punish professionals for truly caring. This has been my greatest motivation for advocacy. So this unexpected hospital death was not identified as an adverse event or a sentinel event. There was no case review, nothing would be learned, no care team debriefing. No one contacted me after that morning. So I deciphered the chart, interviewed the practitioners, began to put some pieces together. I wanted to know why my husband had died. The nature of the surgery that would immobilize Nick placed him at high risk for delirium, given his age, comorbidities, and length of surgery. Being confined to bed, the halted occupational therapy may have supported delirium. I would offer that mobility and mentation are poorly recorded in the chart. Nick had a hard time to clear his lungs after the 7-hour general anesthesia. His lack of mobility supported respiratory decline. His increasingly labored and congested breathing is poorly recorded in the chart. Symptoms of C. diff interfered with being fed, so at death, Nick had eaten nothing in 8 days. Nutrition is poorly recorded in the chart. Sleep. After one restful night, Nick enjoyed 8 hours of deep sleep over the next 7 days until death. Not more than 2 hours of deep sleep in the last 5 days. Sleep is poorly recorded in the chart. So I could continue to add more puzzle pieces to build up a more complete view, a more medically informed view. But the obvious fact is, everything about a patient is interconnected. I knew that this was a system full of caring individuals. How could such a fragmented, silo-bound system so isolate that devastated care team? How could this be? So I looked at core values. Beyond the familiar Hippocrates. Now, above all, do no harm. Doesn't this sound like the medical insurer? This is a practitioner-centered anchor. So I looked 1,000 years earlier. So we find Joshua, and he searches for reassurance and solace from God, Yahweh, or Allah, depending if you look at the Old Testament or the Torah or early Islamic writing. And what he gets from his God is, I shall not forsake thee. Healthcare is ultimately based on trust. This is the basis of the therapeutic relationship. So here's an image of the archetypal physician in the 19th century. The doctor couldn't do much more than watch vigil over this sick child. The child's father stands watchfully, respectfully in the shadows. Now, the 20th century introduced a lot of interventions that banished childhood illnesses like vaccines, the miracle of antibiotics, and sophisticated technology. So has this become the patient's view of trust? Just trust me, I know what I'm doing. I'm the sophisticated technologist. And this is the way we often, as healthcare professionals, see the therapeutic relationship. The patient has all but disappeared. And perhaps mythology gets in the way from the provider. How can it be that any healthcare practitioner can see themselves with this sort of solo role and skill level? I think this is what healthcare really looks like. I think it's highly complex. So imagine me as the patient in the middle, and there's some microbes on the scalpel that's poised over my knee. But in the far left corner, there are a couple of purple dots there at the reprocessing plant 3 weeks ago, where a technician packaged that scalpel badly, and those microbes attached to the steel. So I'm related, and my health is poised on an activity in a different place at a different time. No one in the operating theater feels connected to that technician, and that technician doesn't feel connected to me at all. No one is operating as one. So other things are changing in healthcare. This is the cover of the British Medical Journal from May last year. Let the patient revolution begin. And I think that this patient revolution, patients asking for respect and dignity, is going to affect us all profoundly in the rest of our careers, both as professionals and as future patients. Patients want inside of that hierarchy, but I think healthcare practitioners want to see those hierarchies flattened for teamwork as well. And I think that we need to all recognize that we're tied together in relationships of reciprocal trust. We all want everyone at the table. We all want clarity in roles. We want an open flow of information. We want comfort with accountability, including the patient's responsibilities in that trust relationship. So as we undertake a new procedure, something we've never done before, or a new experience, do not forsake me. It's scary. We're not always at our best when we're experiencing something new. Help me learn what's ahead, what the risks may be, and how to take precautions. Help me know where I'm headed along as clear and as familiar a path as we can manage. We need to know that we're invested in each other. As we exchange mutual respect and equal status, it's about my values and preferences, your expertise and guidance. It's about building those resilient relationships so that we can cope with the unexpected when it will certainly arrive. The Canadian sociologist Arthur W. Frank wrote, "In the clinic at bedside where it counts, a healthcare system is people touching each other. Everyone who touches anyone affects that person's healing and affects the further demoralization of medicine or its remoralization. In the moral moment of that touch, there is no system." Can we maintain touch with new technologies, with more specialization, more fragmentation? Do we still invest in trust, recognize the whole person? Does the patient feel like a body part or a procedure on an assembly line. Standardization, regimentation, fragmentation, super-specialization. Is the practitioner a worker on an assembly line? Now, everyone who chose medicine as a career chose to help, to heal, to offer hope. Could we design a more perfect system for burnout? So I would argue that the technical aspects of medicine are not the greatest challenge. It's how we do what we do, and not so much what we do. We've seen this iceberg way too many times in this last few days, and I think we've independently come to it for all the same reason. ERAS addresses many of the gaps in Nick's care, but it is equally about culture, the whole person, you and me, our relationship, and trust. And yes, it's for better patient outcomes, but also to counter burnout and to improve how we practice. It's a matter of culture. Culture keeps technique afloat. So I would welcome your questions and your challenges, and remember, we're all in this together. Thanks so much for your attention.